So thanks everybody for joining. Apologize for the slight logistical challenges this morning, but glad we could all make it. So we were just chatting. Kristine Ashcraft is here with us today from Invitae, and she is going to be talking about pharmacogenomics. There we go.
PGX.
Thank you. I look for the easy acronyms. There's just too many hard words in this field. Let's be clear. But anyway, we're honored to have you here. There are a number of patients on this call who have had Invitae diagnostics, but I feel like there probably could be more as well. And so we're excited to hear you speak today. And I will turn the baton over to you.
Excellent. Well, thank you so much for having me. I'm going to share some slides. The focus of my presentation is on pharmacogenomics. Sounds like you're already aware, and Invitae does offer diagnostic testing as well. So hereditary cancer screening that clearly would also be applicable. But pharmacogenomics, quite simply, is germline genetic testing that helps us understand when our genes would dictate that for some medications, a growing list of medications, we need a higher dose, a lower dose, or a different medication altogether. In terms of the problem, this helps us address non-optimized medications are a major public health problem. We do lose a life every 2 minutes in the United States to non-optimized medications. In 2016, the last time it was measured, we spent $528 billion nationally on non-optimized medications, which is more than we spent on the drugs themselves or on any major chronic disease, including cancer. And applicability in cancer care, greater than 99% of patients will have a pharmacogenetic variation that impacts their response to, on average, more than 10 commonly prescribed medications. And the more medications you're taking, the more likely you are to have a problem. Although this may not impact a prostate cancer medication per se, it can impact the overall medication regimen and have impact on the overall health of a patient. About half the medications that are prescribed to patients do not work as intended, ranging from about 38% of antidepressants up to 3/4 of cancer medications. Genetic variability is not the only thing at play here, but it is a major contributor to treatment failure. Very interesting analysis came out of the UK last year. They looked at just shy of 500,000 patients in the UK Biobank, and again confirmed that greater than 99% of individuals have an atypical response to at least one medication, on average 10 drugs. And the other thing that was interesting, they had longitudinal data in primary care of the medications that were prescribed for these patients over time. And they found that 1 in 5 new prescriptions in primary care was impacted by pharmacogenomics, and 1 in 11 would have specific drug or dose change guidance associated with them. This is a snapshot of some and not all of the medications that are impacted by high evidence drug gene interactions, meaning that if testing is done, there is specific guidance if a variation is found on how you would consider modifying drug or dose selection based on that information. I bolded the medications that I think you may come across in prostate cancer care. I know statins sometimes are utilized. There's certainly pain management, some antiemetics. But thing to keep in mind over here on the right in the pie chart is that these same genes impact drug response across all sorts of different clinical areas for life. I think of pharmacogenetic profiling, something like a seatbelt for medication management that really needs to be used every time a medication decision is made the rest of a patient's life to understand if they need a different drug or dose. A lot of studies, we're actually working on one in the impact in cancer care right now, but these are more broad, just showing that this can be very helpful for patient care. This was a study that was done in patients 65 and older, taking at least 3 medications, one of which was known to have high evidence drug gene interactions at minimum. And what was seen in just 4 months, 71% fewer emergency department visits, 39% fewer hospitalizations, saving $11.32 per patient prior to the cost of testing. Follow-up study, this was done in patients that were flagged as being at high risk of readmission. And this was a program that was already doing an exceptionally good job. They were in the top 10th percentile for lowest readmission rates in the country. And that's because they had a very proactive program where pharmacists would actually visit the patients in the home and review their medications, because medication-related issues are one of the main reasons patients end up back in the hospital. So these pharmacists were either randomized to give the patients treatment as usual, high-touch pharmacy care, or they were given access to pharmacogenetic testing and improved clinical decision support that didn't just look at drug-drug, but also drug-gene interactions and cumulative interaction risks. And what was seen in just 60 days, 42% fewer emergency department visits, 52% fewer readmissions. It was not an endpoint of the study, but 85% fewer deaths, saving $43.82 a patient in just 2 months. Quick lesson in pharmacogenetics. Generally, when we do testing, we're looking at these drug metabolizing enzymes, mainly cytochromes, that mainly express in the liver. And we place people into different categories or phenotypes based on the genetic information. Generally, when we prescribe medications, we assume all patients are normal metabolizers, also called extensive metabolizers in the literature. And I think of this like a 2-lane highway. So you take medications, they have to go through these enzymes to be converted to something the body can then flush out and get rid of. So your normal metabolizer has 2 lanes of this highway that processes medications. Intermediate metabolizers, 1 active and 1 inactive gene, so down to 1 lane of this highway. Poor metabolizers have no or very, very reduced activity, so no lanes. And then the ultra rapid metabolizers have duplications or upregulation, so additional lanes of these drug metabolizing highways. Difference between active drugs and prodrugs. So most medications, when we take them in an active form. They hit often, again, these cytochromes or CYPs in the liver. These drug metabolizing highways can be converted to something we then flush out and get rid of. Prodrugs are different. Not a prostate cancer drug, but tamoxifen, for example, is commonly given to prevent breast cancer recurrence. It is a prodrug. So it is taken in an inactive form. It hits these drug metabolizing enzymes in the liver, specifically cytochrome P452D6, to be converted to endoxifen in this instance. And then that has to go through again to be converted to something the body can then flush out and get rid of. Bring that up because you're going to have a different response if it's an active drug versus a prodrug if you have a pharmacogenetic variation. So poor metabolizers, those with no lanes of this drug metabolizing highway, are at risk of toxicity over time. So they're not able to process the medication out. They keep taking the dose every day over time. It's going to build up in their body and they can have adverse effects. Intermediate and normal metabolizers tend to be in range. And then your ultra rapid metabolizers process the medication out so quickly that they are at risk of treatment failure. You can see these little dotted lines here. We've got a toxic and therapeutic levels sign. And this is your therapeutic range. Some drugs have a very narrow therapeutic range and some have a very wide therapeutic range. So these variants can be impactful even for intermediate metabolizers, for example, if that narrow, it's a narrow range drug. And it's the exact flip for prodrugs. An example here you may be quite familiar with, tramadol, codeine. These are very commonly prescribed pain medications. They are prodrugs. They are taken in an inactive form. They do not give any pain relief until they're converted. And so if you're an ultra rapid metabolizer, codeine, for example, is converted to morphine by CYP2D6. If you're an ultra rapid metabolizer, you convert so much to morphine, you're at risk of toxicity. They've actually put a black box warning on codeine and tramadol, recommending it not be given to children or nursing mothers because of cases of severe toxicity, including death. On the opposite end, your poor metabolizers are not going to make that conversion, so they will get zero pain relief from these medications. Nomenclature, I've been tossing it about the CYP or cytochrome family, or the main, I would say, the 80-20 rule. These are always going to be the most important pharmacogenes. And you'll see the cytochrome is reduced to CYP. and then 2C19, 2D6, 2C9, etc. Unlike some other things you may be familiar with, we categorize different variants into alleles. And so you will see this come out as like *1/*2. Three main sources for PGX information. CPIC, if you remember nothing else I tell you, this is a great reference. If you go to Google and type in CPIC, CPIC, and drug and genes, it pulls up a great table. And you can key in any medication that is being offered to you and see whether there is a CPIC guideline for drug or dose change guidance or FDA guidance on how that medication would be modified and which gene is impacted. So a great resource, they update it all the time. PharmGKB aggregates data on genetic variant drug response. It feeds into CPIC. Then of course the FDA. This is an important one because newly approved drugs, more and more of them have pharmacogenetic guidance in the drug approval in the label. So for CPIC, key thing to keep in mind, they assign levels. And level A or B is really the one that a lot of laboratories focus on, including Invitae. Level A or B means that when we have that information, we can actually provide guidance on how to act on it. So there's going to be drug or dose change information associated with that guideline. C or D usually means developing evidence or the evidence is weak. So again, focus on the A, B. These are the medications that currently have high evidence drug gene applications in oncology. Again, I don't see prostate cancer. I know sometimes drugs are used depending on the type of cancer that aren't necessarily in that area. So I'm not sure if any of these are ever used in prostate care, but these are the drug gene pairs that currently have high evidence. And do feel free to chime in at any time if there are questions. And you can see very specific guidance. And often if it says dose reduction, there's very specific guidance on what that dose reduction should be. This is just a summary when patients are tested and found to have this genetic type. I think one of the biggest examples we hear about quite often is DPYD for fluorouracil or capecitabine metabolism. This is a sad story about Lynn Stevens. She was a former machinist who was actually in a landmark strike for equal pay for women. In late 2018, she was diagnosed with early stage bowel cancer following routine screening, had a successful bowel resection surgery, and her doctors recommended chemo to knock out any residual cells. Her and her husband agreed that this was the best approach. In March 2019, she had her first and last dose of 5-FU. She died less than 4 weeks later, but not from the cancer. Her husband said her last weeks were agony. Her entire digestive tract was burnt as if by acid. She had constant nausea and diarrhea and couldn't process food. No one warned us this might happen, yet as I know now, Lynn's death was avoidable. So Lynn, like an estimated 1 in 20 people with white European ancestry, produced less of a liver enzyme called DPYD. 1 in 100 produced no enzyme. Without this, 5-FU stays in the body and results in extensive toxicity. This is just a snapshot of a report, a personalized prescribing report that you can see has dosing guidance. It doesn't say you have to avoid this medication. You simply have the dose when you have this on the front end to avoid these toxicities in patients with this genetic type. This came out recently, I think last year. Carriers of DPYD.
Can I ask a question, please?
Yeah, of course.
Is this measure, are you looking for some gene that's missing, or can you actually measure whether the enzyme is present in the serum?
Yeah, you can do both. This is actually looking at the gene, but there are a number of studies that have correlated the levels with the gene.
And what do people do in practice for this drug? It's obviously a risk that someone needs to mitigate.
Yeah. There are some cancer centers that are starting to utilize this. OHSU, and I think that's actually in here, got sued earlier this year because wife lost her husband because they didn't even explain the risks or that this testing was available. And they now have to talk to every cancer patient about it and make them aware that this is a risk and the testing is available.
I'm amazed that this isn't widespread known and tested for.
It should be. I actually wrote a letter to NCCN to update the guidelines just last month. There's been a bit of resistance. And I think a lot of times people don't order things unless it makes it into guidelines. It currently says there's a correlation, but they don't recommend or say you should test the patient.
Well, sorry, Kristine, why would there be resistance? I mean,
I will send you an article that Turner Ray just wrote up in Genome Web about this. She actually interviewed a ton of people. It's a great question. I don't know why there is resistance, but there has been resistance to pharmacogenomics in general my entire career of over 20 years in this space.
No one in my 6-year journey, no one has brought up this topic of, there might be certain genes that that may be indicators that I'm not going to respond to a particular drug. The other question that I had is just, and maybe you're going to get to this, is around dosing. Like, how do you, it's a one size fits all when you get treated, how do we use this capability to optimize dosing for patients? And is that something that you even get involved in? Because Kristine, actually, sorry, one more little caveat here. My fault, but I didn't even know that Invitae was in this space.
Yeah.
I look at our patients, and so we've got 6 patients right now with prostate cancer lab. 5 of us have your germline sequencing, which is negative for all but one person who had BRCA2. But nobody ever talks about the pharmacogenomics that you all do. So why is this not more prevalent? And how do we get access to it?
Yeah, it's a great question. So just like any other Invitae test, we have a $250 patient pay rate if insurance doesn't cover it. One of the barriers, just like any other biomarker testing historically, has been reimbursement. Medicare did implement local coverage determinations in 2020 that dramatically expanded coverage. It aligns with the FDA or CPIC-AB. So if a patient is either taking or a medication is under consideration that impacts 2 genes, they will cover a full panel 100%. But a lot of the issue, and the pharmacogenomics community is certainly working on this, is that guidelines and reimbursement policies do not align with the evidence. They're outdated. I know I'm on the pharmacogenomics subcommittee or something for the American Cancer Society. They've been pushing biomarker legislation across the country that mandates coverage for biomarker testing, including pharmacogenomics. There's an effort right now in California, and if anybody on the call is in California, please email the governor and ask him to sign SB 1191. This would mandate pharmacogenomic coverage for Medi-Cal patients that aligns with the Medicare coverage determination, CPIC-AB. But I'd say the other big thing, to your point, is there's a lack of education. There is a federal act called the Right Drug Dose Now Act that Swalwell and Emmer introduced in February that would mandate money allocated for both provider and patient education about the importance of pharmacogenomics, the evidence behind it, and how it can help reduce adverse drug events, among other things. But all very good questions. But pharmacogenomics, if you're familiar with Invitae, can be ordered just like any other test and follows the same kind of assessment, whether it'll be covered, giving the patient the option to switch to patient pay, et cetera, patient assistance program for those that have financial need.
Super helpful. Thank you.
Yeah. So this meta-analysis, patients with variants over 25 times more likely to have treatment-related death. Europe has mandated testing since 2020. And I think the main point I want to drive home is, although there may not be specific prostate cancer medications that have drug gene guidance, a lot of the medications that cancer patients need are impacted by pharmacogenomics. And it's really important to optimize the overall health of the patient as much as we can. We don't want them getting too much of a beta blocker, for example, that makes them fall and break their hip if we can avoid it, even though it has nothing to do with their specific cancer medications. But a lot of medications with PGX impact commonly given to patients. And I will get your dosing question in just a moment when I demo the software Invitae includes for providers with testing. I did see that ADTs and statins are sometimes used in cancer treatment. You can see there are a number of statins that are impacted by pharmacogenetic variability. Specifically, SLCO1B1 is associated with increased risk of muscle issues, statin myopathy. And so if you have this testing proactively, it can guide you to a statin that's going to be lower risk for the patient if it's needed. Other big thing that I find very interesting, so they haven't done a lot of testing in opioid dependency treatment, but when they do, the rate of CYP2D6 ultra rapid and poor metabolizers is 3 times higher than it is in the general US population, leading me to believe that we're either underdosing or overdosing these people, and it leads to downhill or downstream effects that are potentially avoidable. These are the medications currently with high evidence drug gene interactions for pain management. I did see that NSAIDs for reducing inflammation are sometimes used to help, but I'm sure also pain management important in general in cancer care. And this is, I'm going to actually pop through this and go to the dosing guidance. This is the Medicare expanded coverage in terms of any patients that have Medicare. They have very good coverage for pharmacogenetic panels. So would encourage ordering, especially for any Medicare patient, the same time you do hereditary cancer testing. It's a great time to order the pharmacogenomic testing as well. There's one more thing before I pop into the clinical decision support tool that shows you the dosing, because it's a premise for the clinical decision support tool. There's drug gene interactions, but the drugs that patients take at the same time do something called phenoconversion. If you remember from my lanes analogy, intermediate metabolizers, one active, one inactive gene down to one lane. If they're taking an inhibitor of the same enzyme, it essentially sends a signal to their body. It's a drug that says, hey, shut that other lane down. And we have essentially phenoconverted them to a poor metabolizer as long as they're taking that other medication. An analysis that came out of Austria showed that 1 in 4 patients were taking a PGX med at the same time as an inducer inhibitor of that same enzyme. Inducer does the opposite, sends a signal to make more of the enzyme to the body. So very similar response if you're familiar with drug-drug interactions of the cytochromes. So a poor metabolizer, again, no lanes of this highway. Inhibitors are different strengths. Some may say shut down both lanes, some only one lane or half a lane. And then the ultra rapid metabolizer is very much like an inducer, sending a signal to the body to process something more quickly. Again, the difference being the genes will never go away. And this is an example, again, using tamoxifen of what happens when we don't take these drugs into account at the same time we take the genetics into account. On the far right, we have variant type. This is a poor metabolizer for CYP2D6, and there are levels of endoxifen in the system. Right next to that, we have wild type, a normal metabolizer, taking paroxetine. You can see their levels are pretty low, even though they are a normal metabolizer for CYP2D6. And then as we shift to the left, these other medications also have an impact on reducing levels, but they're not as strong of an inhibitor of 2D6 as the paroxetine is. But if you have an intermediate metabolizer, for example, and you're giving them sertraline, they're going to shift further over to the right. So just something to keep in mind that this is very important. And pop over to the software. So when a patient is tested in Invitae, we ask the ordering provider to submit the cheek swab sample. We can take a blood sample if one's being drawn anyway. And a list of all the medications a patient is currently taking, as well as any that are under consideration for their care. And we will provide 3 different reports. One is just a standard lab report. Your patient's a 2D6 intermediate metabolizer, star 1, star 4. The second is a personalized prescribing report, which is essentially grabbing the information from the demo I'm about to show you. And then the third is a high evidence drug gene table. This is a summary that goes to the patient and provider that will include any of the current high evidence medications that could be problematic by category.
Kristine, just one quick question. There are a number of patients that take supplements.
Yes.
Do you also account for supplements beyond just meds?
We do if there's information in the literature about interactions. Unfortunately, not all of that has been well studied, but if there are publications on known interactions, we will have that in there as well.
Got it.
All right, I'm gonna forget my, it's Francisco. And I will, if you have, I'm just gonna walk through an example, but if there are medications you want me to add here, I'm happy to do so. So this is a patient prior to testing. We've entered in some medications for the patient and already have one moderate interaction that is flagging based on the medications alone. Drawing you the information at the top here. So these are the different medications. These are the genes. Anytime it says recommended next to the gene, that means that there is a high evidence drug gene interaction. I will email you all a high evidence drug gene table after this. This includes all the medications that currently have high evidence. This aligns with Medicare coverage, but also with guidelines. So CPIC, AB, or FDA. You can see, for example, the fluorouracil for DPYD, irinotecan for UGT1A1, both have testing recommended. So for a Medicare patient, if you said, hey, irinotecan and 5-FU are under consideration, boom, they cover a panel. But some are optional. These are developing evidence genes. So we can't yet tell you how to act on the information. But some people want it anyway. It is in the notes. Let me show you what that looks like tested. So if you are familiar with the Invitae portal, when the patient is tested, we will automatically port their results over, as well as the medications provided at the time of testing. And this gives you a summary of all the information and also enables you to audition any new medications, find safer alternates, et cetera. So if we pop into the fluorouracil, you can see that there's a summary. This is what comes out on the personalized prescribing report, just these succinct bullets from the software. There's increased risk for these adverse effects. You want to initiate dose at half of what you would normally do. If there's minimal toxicity, you can increase the dose. You do want to dive into the underlying reason behind that. There are detailed effects in management. We have curated over 17,000 publications and product inserts. All of our pharmacists are CPIC members, so they add new FDA-approved medications, new CPIC guidelines. We also bring in content from Elsevier Gold Standard on drug-drug, drug-herbal interactions, et cetera. But this will go out to the underlying reference if you really want to dive in to the detailed effects in management. So I will give you an example, and we can pop in different medications if that's helpful. But if we go to the metabolism tab here, what we do with UScript, and this is my baby, I used to be CEO of UScript, is make it easier to understand when drugs and genes or just multiple drugs are combining to cause more significant increases or decreases in drug exposure than the binary components. So this is an example with metoprolol, but I will do the same thing for you if there's a drug-herbal gene interaction. In this instance, we are expecting a 76 to 200% increase in drug exposure because the patient's a 2D6 intermediate metabolizer. Metoprolol is metabolized by 2D6. We're also expecting a 26 to 75% increase in drug exposure because the patient is taking fluoxetine, which is an inhibitor of 2D6, a slight inhibitor. The combined impact is a greater than 200% increase in drug exposure. You could use this to help titrate the dose. If you want specific information on the exact ranges that we're seeing, you can actually pop onto those notes, and a lot of times they will actually have the exposure ranges in there as well. We can't get to the point of saying this means give them 3 times the dose or 1/3 of the dose, because if we did, we would be considered a medical device by the FDA, and we would not like to do that. This is a provider-facing clinical decision support tool, so we do try to make it as easy as possible. So the other thing that is helpful is this alternates. So maybe you're like, hey, I'm not really sure how to dose this, so I want to give them a different medication instead. And either by class or indication, you can find medications that are going to reduce the interaction potential, taking everything you've entered into account. You could also add other things. You just type it in. St. John's wort, for example, interacts with everything, I think. And so you can go in and find a one-click alternative, and it will take everything again in the left into account. You could do a one-click substitution. It'll deselect what you had in there, add the new medication, and you can see, just as we saw on the right, that comes through as just monitor. I don't know, Brian, if that answers your question about the dosing.
It does. Okay, just for grins and giggles.
Yeah.
I know a lot of patients on the call are taking Lupron. So what does that look like? There you go.
So Lupron doesn't have this DNA double helix next to it, which means at this point there's no high evidence drug gene interaction. There are a few just monitor interactions for different things you can look into, but yeah, different type of metabolism. It'll have the most common adverse effects.
Mm-hmm.
Yeah.
Great. Any other questions on this part from?
Yeah. Any other medications anybody wants to pop in here?
What's the next part of the talk?
Yeah. So next part of the talk, just kind of a summary of takeaways. So a lot of times historically, we have done pharmacogenetics a gene at a time. We'll be like, oh, we're going to put the patient on irinotecan. Let's order UGT1A1. At this point, laboratories, whether it's Invitae or another laboratory, are running multi-gene panels. And if only a single gene is ordered, we only report on that gene. And the cost is no higher for us to report on all of these genes. We currently at Invitae have a 38 gene panel. It includes high evidence drug gene pairs for 98% of high evidence drug gene pairs, aside from those that are specifically for disease diagnosis, germline. They impact genes across many, many diseases. And so you really need to, if there is a trigger point to order this, ideally do it once. Continue using that information to optimize drug and dose selection. Vitally important for patients to share it with all of their prescribers, for ordering providers to make it clear to patients that this can impact drug response across multiple areas for life. And just an example of why this can be so important across different areas. One of the early use cases for pharmacogenetics was clopidogrel or Plavix. This is a drug that's commonly given to keep a patient from having another heart attack or stroke. It's a prodrug. Doesn't work if you're a poor metabolizer, reduced efficacy if you're an intermediate. Patients with variants are 3.5 times more likely to have another heart attack or stroke on the drug. So we looked at patients that were referred to us for testing on Plavix, and what we found is 16% didn't have any gene-based prescribing suggestion. 22% had only 2 C19, so maybe more than Plavix even. And over 60% had another high evidence drug gene interaction or another gene in the panel. So just a reminder that this is something that could be done once in a lifetime that can really help optimize drug and dose selection across a lot of different areas. And then questions. Hopefully there are more.
Yeah, I've got a few. So it sounds like germline doesn't change, right? During a
Correct.
lifetime. So why isn't everyone get it at birth and then you use it your whole life?
I am a big proponent of that. I think we should be doing that.
So that's a Canton Vitae, you do some natal testing as well, company?
We do a lot of testing from prior to birth, right at birth, across the entire continuum.
So is this a marketing decision, or you guys can position products that way and differentiate yourself in the market? Another question is, if I am a cancer patient getting a whole genome sequence, I should be able to pull this information out of that. True, the same genes, the liver.
Yeah, it depends. There are some complications sometimes. So CYP2D6 is it requires the data to be done in a certain way to properly call CYP2D6. It's very complicated. It has a pseudogene issue. The duplications for 2D6 that make a patient an ultra rapid metabolizer need to be interpreted in a certain way. And that's a very, very important pharmacogene. CYP2D6 metabolizes about a quarter of commonly prescribed medications. So it's possible, but you have to have it set up the right way to read.
At the other extreme, does that stuff come out of the $99, 23andMe panels?
Yeah, so the 23andMe panel has very low SNP coverage. And so if you are found to be an intermediate or poor metabolizer, I would trust it. If you are found to be a normal metabolizer, it quite likely could be missing a variant, especially if you're not of European white ancestry.
Okay, and then finally, my favorite dream is to figure out how to dose people by actually measuring how much active blood, drug is in the blood, or how much is even better reaching the tumor, yes. And modulate dose empirically as opposed to prescriptively. Does that make any sense?
I think they go hand in hand. In my perfect world, I would test patients at birth as well and have this as part of a permanent and portable medical record that doesn't get trapped in different EHRs or doctor systems. But using that as a guide. So instead of starting this patient on a standard dose in a one-size-fits-all manner, I'm going to start them at half of the dose. And then I'll do therapeutic drug monitoring to see if that was the right choice. So
Invitae bought Citizen, right?
Yes.
Do you guys talk to the Citizen folks about trying to couple this kind of testing to the medical record?
Yes. There are a lot of things we were planning to do at Invitae. Unfortunately, there's good and bad. It's a large, multi-pronged company. So yes, we do plan to do that, make it easier to add pharmacogenetic testing to any other order, for example. But it takes time to add things and websites. And right now, the pharmacogenetic testing is run in Seattle, in our lab there. And most of our other testing is run in the San Francisco lab. We do have different labs as well that do some of the more specialized testing. So,
okay, I may have someone named Rebecca Driscoll get in touch with you, who's the CEO of Cancer Commons, and we recommend to thousands of patients a year one thing or another, and maybe there's a way to integrate what you guys offer into our recommendations in some kind of a. So keep the name in mind, Rebecca Driscoll, Cancer Commons, because she'll be following up with you.
Thank you.
Thanks, Marty. Any other questions?
Sorry, my dog has one apparently.
So maybe while folks are formulating their questions, I'll jump in with another one. So I just looked at, one of our patients' Invitae report, the germline sequencing report. Obviously, you don't have this information integrated into that report. We kind of talked a little bit about, about that model. And as a patient, like I had no idea that this was even a possibility. But it seems to me like the easiest thing to do is to integrate it into their germline sequencing report. What would be the cost of that? Or how could we get access to this information if it's not integrated into those reports?
Yeah, so currently it needs to be ordered as a separate test. It's a separate sample that's sent to a different lab. So The hereditary cancer testing is done in San Francisco. The pharmacogenetic testing is a genomass array. It's done in Seattle. We are working right now on some very cool stuff that will enable us to put a lot more on a single platform, but that's early in development. I think that will make things a lot easier in the long run, but I'd say at least for another year or so, we're still going to be in these kind of separate. So you have to order it as a separate test if you're using the Invitae portal. The same way, if you have an EHR integration, you would ask to have the PGX added to the compendium.
Got it. Rick, looks like you have a question.
No, I had to take care of some doctor personal stuff, so I was in and out. I'm sorry. I don't have any questions. I feel fairly comfortable with what you presented and what I was able to pay attention to. I've done similar work at Human Longevity. I don't have any questions at this time, and thank you.
Yeah, I have questions. Like you're like, why haven't we heard of this? And it sounded like Marty had a suggestion for Cancer Commons. If you have any suggestions on how we can do a better job, I'm on way too many PGX committees to count, but we are trying to get the word out to providers and patients. So we're all ears. If you have any recommendations on how we can do a better job of sharing this information. I'm clearly, after 20 years, a big believer. I think this can both improve patient care and reduce costs. I think it's the right thing to do, especially for patients that have to take a lot of medications.
Yeah, so that's a great question, Kristine. So, our community here is very focused on prostate cancer, but even within that segment, we do have access to a number of resources that publish. So I was just interviewed yesterday for a story, a couple of weeks ago for a story as well. So, there are opportunities for us to help you to get that word out. And so now that I know about this, I certainly will be an advocate. I'm sure that there will be others on this call that feel the same way, that have access to, some of these megaphones that can help to spread the word. Obviously, having these questions, one-on-one with your clinician is obviously helpful, but there are bigger platforms, I think. Brad's got his hand up. Yeah,
Kristine, one of the original reasons that I reached out to you, because I know you're an expert on pharmacogenomics, but we ran into something, was a question on dosing. And we're proponents, and CureMatch in particular, is of drug combinations. And one of the concerns that prescribing doctors would have is drug-drug interactions, toxicity, and so on. And so how could dosing perhaps solve that? And are there principles and ideas around dosing that would make it safer for patients and more comfortable and confident for doctors to prescribe drug combinations and understand the interactions? Maybe, the rule of thumb was if it's 3 drugs, maybe give a third of the dose if they're not on similar treatment pathways, and not to think of them all like chemo. Anyway, that topic. Do you have any pointers? I think you didn't have any direct answers, but maybe you had some pointers where we should be looking.
Yeah, I think if you are talking about, it depends on how they're metabolized. A lot of the stuff that I was looking at in prostate cancer was small molecules. It was not metabolized through the cytochrome system, which is really the big impact for pharmacogenetics. There are some transporters and receptors we're trying to understand better. But I would say, are you able to do therapeutic drug monitoring to determine what the impact is of these combination therapies? Like, is that measurable? Like, I think once that information is out there and it's published, tools like the UScript clinical decision support tool, we love data. We feed it in and then we say, hey, when you give these together, this is what you expect to see. But in order to feed that into clinical decision support tools, and we're not the only one, we actually need to see published data that when this combination is given, this is what happens. Or, we see these, it's feasible, but you need to have the published data to feed into it. I don't know if that's helpful.
That's
it's
helpful.
it's a little, that's a little bit our conundrum, because many of these personalized cocktail combinations don't have evidence because they're so personalized.
Can I add how we use this information directly, since it's about combinations? May I?
Yeah, we have about 30 seconds, and then I know some others have another call. So I'm actually going to stop the recording.